All right, opioid use disorder, pharmacology, the addiction model of disease, MOUD, and more. What are opioids? One of the most important aspects of understanding how someone begins with a pill at a party and ends up having a substance use disorder is to understand how opioids work in the central nervous system. Opioids are a diverse group of compounds with similar chemical structures and effects, whose unifying characteristics in interaction is the interaction with the opioid receptor. So our body has endogenous opioids, and they attach to mu kappa delta receptors, and they can be helpful because they decrease pain, decrease anxiety, and can also lead to a decreased respiratory drive. There are naturally occurring opioids, and they come from the opium plant, such as morphine, codeine, and heroin. I'm just going to go over basics of pharmacology when it comes to opioid, since it can get pretty complicated. But like I said, there are naturally derived opioids from opium, which can manifest as morphine, codeine, and heroin. There are also semi-synthetic opioids, which are chemical modifications of natural opioids, such as oxycodone, hydrocodone, hydromorphone, oxymorphone, and buprenorphine. Finally, there's synthetic, which are chemically manufactured opioids, and those include methadone, fentanyl, and fentanyl analogs, such as carfentanil, sulfentanil, fentanyl. And the potencies of those, which you guys will see, are much more significant than just fentanyl. So really, to understand the pharmacology, there are a few topics which I'm sure some of you are aware of, but if not, this is a quick refresher. Affinity is how tightly opioids bind to the receptor. Agonism is how large the effect of the binding is on the opioid receptor. Dissociation is how long the binding can last, or how long the opioids are bound to the receptor. And the half-life kind of goes hand in hand with the dissociation. So how long it takes for the drug to be metabolized. The reason pharmacology matters is because it can tell us what dose can lead to what effect. This picture is from the DEA website. It depicts a lethal dose of heroin, fentanyl, and carfentanil. Fentanyl and carfentanil have high affinity, high agonism for displacing heroin from the opioid receptor, causing a 50 times greater effect than heroin. So how does opioid use disorder occur? Currently, we see opioid use disorder in a disease-modeled state. Addiction is an acquired disease of the brain. Stages of addiction are consistent across substances. Social and biological factors contribute. Of note, only 10% of people exposed to addictive drugs develop the most severe phenotype of addiction. So it stands to reason that there must be some patient-specific factor that increases their vulnerability to substance use disorder. Known factors are family history of addiction, early exposure, so during adolescence, makes people more likely to develop an addiction due to greater neuroplasticity, and high-risk environments such as social stressors, poor family support, social support, and underlying mental illness. So this kind of gets into the nitty-gritty of the disease model of addiction. This is created by Dr. Nora Volkoff, which is a prominent addiction researcher for NIDA. For the purposes of today, we'll try to keep the neuroanatomy relatively simple and focus on the big picture. There are 3 stages of addiction there's the binging and intoxication. there's withdrawal and the negative effects, and the preoccupation and anticipation that can occur when trying. Yeah, they're labeled in this when developing an addiction. In the case for most patients with opioid use disorder, when they first use opioids, they feel euphoric. And in fact, many of our patients tell us they are forever chasing that first high. After the euphoria wears off, they might feel reduced energy and they look forward to the next time they can use. But what happens over time, as the revolution of the cycle increases throughout frequent use, the balance begins to shift. Instead of feeling euphoric, individuals feel good, and when they come down, they start feeling some negative effects, desiring the drug in a way that is starting to impact the green structure, the orbital frontal cortex, the seat of decision making. And finally, an individual with a severe opioid use disorder is no longer attempting to get high, but trying to escape the cycle of dysphoria. And when the effects wear off, there is significant negative consequence, which leads patients to obsess, plan, and rewire all circuitry within the seat of decision-making towards acquisition of opioids. Quite literally, the neural connections of their brain have been hijacked, adapted to accommodate and prioritize one thing. So this is I'm going to go over a diagram of the scientific basis for opioid addiction. So these represent opioid receptors in a simplistic way. When we're exposed to pleasurable stimuli, such as food, sex, water, we release endogenous opioids, which are exemplified in the purple. They bind to opioid receptors to give us a feeling of pleasure. Physiologically, this binding also induces pain relief, slower breathing, and relaxed bowel movements. So you guys can see the slides, right? Everything's okay? All right. When patients use heroin, Oxycontin, or fentanyl, these exogenous opioids depicted in black, they have a much higher affinity to the opioid receptors, binding tightly and displacing our natural endogenous opioids. And initially, this feels great. There's euphoria. However, over chronic use with chronic opioids, what happens is several patterns emerge. The body becomes accustomed to the binding of exogenous opioids and starts to require larger and larger quantities of these products to produce the same effect. This is the physiological concept of tolerance. The body becomes accustomed to the binding. Furthermore, due to the constant presence of exogenous opioids, the body responds by appropriately decreasing endogenous opioids. So now the experience of normal pleasure of everyday life, you may need an exogenous supply of opioids. So the purple opioids, endogenous opioids, are removed. And finally, when you don't have the compounds on board and your body does not produce its own opioids, these unbound receptors begin to activate an alarm telling the body that it requires more opioids through painful, intense stimuli. This physiological concept is called withdrawal. So now getting into the nitty-gritty, this DSM-5 definition of opioid use disorder. This is a problematic pattern of opioid use leading to significant impairment or distress manifested by 2 or more criteria within the past 12 months. So taking increasing amounts of opioids, a persistent desire or unsuccessful effort to cut down, time spent obtaining or using or recovering from opioids, cravings, use that prevents fulfilling obligations, social or interpersonal problems, giving up important activities, physical harm, being in physically harmful situations, physical or psychological problems, tolerance, and withdrawal. So what are the complications of opioid use disorder? I'm sure a lot of you have seen this diagram, but if you haven't, this is a CDC diagram of US drug overdose deaths over the past 20 years. Um, as you can see, there's been a few spikes along the way. The red depicts all drug use. The green, as you can tell, is going up is drug all opioid use. And then finally, the last light green is the synthetic opioid use. And that is the triple wave. While opioids have been around for centuries, the modern opioid epidemic started in the late 1990s and have been characterized by three distinct waves. The first wave of opioid overdose death was related to opioid pills. Following a movement with medicine to treat pain, prompted by JCO's guidelines of pain as the fifth vital sign, and buoyed by aggressive directives towards physicians and consumer market by pharmacologic companies, there was a dramatic rise in prescriptions from opioid pain pills. The second wave of deaths was due to heroin, with a parallel rise in injection drug use. As prescription overdose deaths increased, the medical system realized the fast and loose prescriptions were causing real harm. There was an effort to stop all prescriptions. So individuals who developed an opioid use disorder through pills use were finding it more difficult to obtain pills and this correlated directly with an influx in heroin into the US market. Suddenly, people were using cheaper drugs off the street as an alternative. And finally, we're at the third wave currently with synthetic opioid overdose deaths. The deadly slope of this curve supports that we have what we know about the pharmacology of these synthetic opioids. The high affinity plus high agonism, 50 times that of heroin, is causing respiratory depression to the point of death. By and large, the inclusion of fentanyl in the supply is not something desired by most heroin users, who often find that without resources to clarify whether they're being sold fentanyl or laced products. Beyond overdose deaths, there are numerous infectious complications of opioid use that span both disease-related to contamination as well as disease-related to transmission. There's a rise in hepatitis C associated with opioid use disorder, as exemplified by this graph. And HIV outbreaks associated with opioid use disorder. So how do we prevent complications from opioid use? One option is medication for opioid use disorder. I'm going to go into the specifics next. Medications for opioid use disorder. There's 3 FDA-approved treatments for opioid use disorder. Methadone, which is a full agonist, and buprenorphine, which is a partial agonist, and naltrexone, which is an antagonist. Today, we'll mainly talk about opioid agonism, but we can get into naltrexone if anyone has questions or wants to explore that further. So methadone is a synthetic opioid. It's a full agonist at the mu receptor. It's long acting, so its half-life can really vary based on the person's physiology, between 15 to 60 hours. And it can be displaced by a partial antagonist or agonist like buprenorphine and an antagonist like naltrexone. Thus, a patient that's on methadone that starts on buprenorphine can precipitate withdrawal. Methadone is dosed typically once a day. The usual starting dose is 30 milligrams, but more recently, there has been some changes and that dose increase now can go up to 50 milligrams on intake. And there is no upper limit of methadone, but it can usually around 200 and above 200 is the upper limit. It's variable in terms of what most patients need, because currently with the fentanyl epidemic, patients are needing much higher doses than they had when they were previously on heroin. But in the past, the average dose was around 60 to 100 milligrams. Patients are prescribed methadone from an opioid treatment program. It's not dispensed at pharmacies. They have to get it from an OTP or an opioid treatment program. On intake, they get a medical assessment on typically the first day. And they also get an EKG because methadone does cause QTC prolongation. And most of the guidelines for methadone were actually created in 1974 with the Narcotic Addict Treatment Act. But more recently, there have been some changes that have been seen post-COVID that have loosened some of the strict guidelines that patients have to adhere to when they're started on and placed on methadone. Then there's buprenorphine. Buprenorphine has a high affinity because of its high kappa value and intensity of binding to mu receptors and slow dissociation. So comparatively, it has minimal respiratory suppression and no respiratory arrest when patients are taking it as prescribed. Now, that necessarily doesn't mean patients are taking it prescribed. So if they are, drinking alcohol or using other opioids with it, they are still at risk of overdosing on buprenorphine. But unlike methadone, if they take it as prescribed, they shouldn't have an overdose from the medication. The half-life is 24 to 36 hours. It's pretty long acting and like I said, it has a high affinity to the mu receptors, and it blocks other opioids and displaces other opioids. And that's why when patients are started on it, they have to be in somewhat of a mild to moderate withdrawal state, usually more of the moderate, or they can precipitate withdrawal. So buprenorphine can be dosed once a day. I also dose patients multiple times a day, depending on, what they need for pain control. It's not like required to be dosed once a day. Typically you can start between 8 to 12 milligrams a day and go up. Most patients don't need more than 32 milligrams of buprenorphine. In the past, I think there was challenges with getting prior authorization. I don't know if that's something that is still an issue, but I know in the state of Maryland, it's pretty easy to do same-day dosing if patients want to start on methadone or buprenorphine the same day. With short-acting opioids, like when heroin was mostly on the streets, we would say wait 8 to 12 hours before starting patients on opioids. Wait 8 to 12 hours while patients were on opioids so that they can be in moderate withdrawal before starting the buprenorphine. But now when patients are getting fentanyl, you kind of need to wait a day and a half to 2 days. So 40 hours, 48 hours. If a patient can go that long, they really need to be in moderate withdrawal before initiating buprenorphine, or you can precipitate withdrawal. And studies have found patients do just as well with home induction as in-office induction or initiation. And then you don't need to have a waiver anymore because now pretty much all prescribers can prescribe buprenorphine. Typically, when I start a patient on buprenorphine, I'll titrate up weekly, mostly because that's how frequently I'm seeing them. So just when you're starting patients on buprenorphine, things I like to tell patients before they start, make sure you moisten your mouth before taking the film. Hold the film under your tongue until it's completely dissolved. Don't eat or drink anything for at least 20 to 30 minutes after you take your buprenorphine. And like I said, you still are at risk of overdose if you're using other CNS depressants at the same time. And then also, I give all of my patients Narcan, just to, be safe. Uh, So typically I'll see patients that I've initiated on buprenorphine about weekly, initially, so that I know if I need to go up, I can more comfortably see them, and have them go up. As things stabilize, as their urine drug screens return appropriate, I tend to see them less often. So I'll extend things out to every 2 weeks, every month. Um, some clinics are comfortable seeing them every 2 to 3 months, which is how we do things at our addiction clinic. And some providers require patients to be seen monthly if they're on buprenorphine. Some common side effects that patients may experience are nausea, vomiting, constipation, sweating, dizziness, sedation, headaches, drug withdrawal symptoms, insomnia, and edema. So, that's one thing you would like to make sure you advise your patients that this is not a medication they can just stop on their own because they are going to experience some withdrawal. So they should talk to you about tapering down if that is something they're planning to do. So we kind of went over the two agonist treatment options for opioid use disorder. This is just a quick overview of both of them. Sorry, I don't know why it keeps flipping. So methadone is Schedule 2, whereas buprenorphine is Schedule 3. Methadone is an agonist, whereas buprenorphine is a partial agonist. They both have comparable efficacies for the treatment of opioid use disorder, but methadone has to be distributed through an opioid treatment program, whereas buprenorphine can be given in the clinic office. Methadone, you get dosed daily, and usually need to come to an opioid treatment program daily in the beginning until you've been able to get some take homes. Whereas buprenorphine, typically we see patients weekly to monthly in the clinical setting. And methadone can have a longer duration of action, whereas buprenorphine has, like, within 3 days, patients tell me that they're starting to withdraw. But it tends to be, I think that statement's a little variable. Patients kind of tell me both in terms of what is easier to get off of. So I think that's very patient specific. But it sounds like studies have shown that methadone has a more severe withdrawal, whereas buprenorphine has a less severe withdrawal. So these medications are opioid agonists, also binding to opioid receptors in a different manner than heroin or fentanyl. These medications can prevent or reverse withdrawal symptoms and reestablish a balance in the absence of heroin products. And studies have shown that opioid agonist therapy does decrease IV drug use. And these are both charts that exemplify a decrease in IV drug use based on patients' treatment into programs. However, if patients were to stop treatment, so like the second graph, there's a steady increase over time in return to IV drug use. Opioid agonist therapy also decreases mortality. This data exemplifies a study in Massachusetts that evaluated mortality in patients with a recent non-fatal overdose. Patients not on medication for OUD had the highest rate of mortality, while engagement in treatment was significantly associated with a decrease in mortality for a year after their overdose. Treatment for opioid use disorder also decreases time using daily, time unemployed, days involved in crime, and time incarcerated. And this is all from NIDA. Okay, and then the last treatment option for opioid use disorder is naltrexone. This is a full antagonist, and it binds to the mu receptor and completely blocks other opioids from blocking, and also displaces other opioids because it has a high affinity to the mu receptor. And thus, it can also precipitate withdrawal, similar to buprenorphine. It comes in formulations that include tablet forms, as well as intramuscular injectable forms. However, not all patients necessarily want to stop or reduce their substance use. And not all patients want medications for their substance use. Patients who become abstinent may not want to stay that way. Disregard for the disease. So this kind of goes into a little bit of the harm reduction. There's a pervasive attitude within society and even the medical community that addiction is a behavioral issue rather than a medical disease. There is a misconception, and I'm sure you guys have heard this, or if you haven't, you might, that treatment for opioid use disorder is like replacing one addiction for another. However, there is evidence-based treatment options to treat chronic medical diseases. And I think making sure patients know that this has been studied and it is not the same as getting illicit substances off the street is going to be a big part in advocating for the treatment of their chronic condition. So what is harm reduction? It is a set of practical strategies and concepts aimed at reducing the negative consequences associated with drug use. It's also a social justice movement built on the belief in and respect for the rights of people who are using drugs. So why engage in harm reduction? The focus is for you to get patients engaged where patients are at and not where you want them to be, to empower them and support patients in their decisions and goals. It's to destigmatize drug use and reduce barriers to care to help patients engage in care. So this is just examples of one of the ways harm reduction benefits patients. It's showing syringes that are given out to patients so they don't have to, reuse needles and, increase their risk of infection or exchange needles so that they won't be at risk of getting skin and soft tissue infections and or HIV or hepatitis C. There's also, talking to patients about various ways that they're injecting and how one method could be increasing their risk of certain types of infections, especially if they have a lot of skin and soft tissue infection. Because the goal of harm reduction is to minimize the harm of their use, which might include minimizing how they're using. So counseling them about safer injection sites. And then finally, one of the big pushes with harm reduction is naloxone distribution, because that has been shown to decrease opioid overdose deaths. So there's been a 46% decrease in overdose deaths just from naloxone distribution. You'll see I think there's two sites, one in New York, one in Philadelphia, that has overdose prevention sites where they more safely monitor patients that do want to use illicit opioids. And there's, this is a great slide that you can see, but it basically describes the benefits of such programs because it increases exposure for them to get substance use treatment. It can reduce the amount they use and frequency of use. It can reduce behaviors associated with HIV and hepatitis C acquisition, and it increases our ability to deliver medical and social services. And so this is just more pictures of harm reduction sites. I know there was a request to kind of talk about street names. I think some of the more common ones that I've seen in Baltimore, usually for fentanyl, include like Scramble, Dope, but these are the ones that NIDA has published as of July 2017 that they've seen. A lot of what we see right now is not heroin, it's mostly fentanyl. And so I think that also kind of is something to be aware of. And so that is like a quick overview of everything. I want to make sure I leave time for questions. I have additional slides I can go over with you guys if we don't have much for questions, but I did want to pause and see if anyone had any specific topics or anything they wanted me to discuss further in this talk. You see there's some talks.
There was some questions in the chat.
Okay.
I'm sure I'm gonna butcher this. Somebody wrote pathophysiology of the edema, question mark.
One second. Okay. I think it's one of those things where they, you know, I don't think it necessarily has an etiology. I think it's more like they did the studies and they found that some patients were getting more swollen. I necessarily have not seen it in practice, but it's just what's on the label for what patients are supposed to or have reported in the past. But I think it's pretty rare. I can try to figure out how commonly it happens, but I have not seen it all that often. I don't know if anyone else has seen any edema in buprenorphine. But that's an interesting question on how frequently it actually happens.
Another question was only methadone causes QTC prolongation.
Sorry, I can't hear you. One more time, can you?
Yeah, can you hear me?
I can, yeah.
Okay, only methadone causes QTC prolongation.
So it is put on the label for buprenorphine, but typically it isn't the same as methadone. Methadone is probably the primary culprit for QTC prolongation. I actually don't even check EKGs on my patients that I'm starting on buprenorphine. So I'm not worried about it. And even though I think it's like less than 1% of patients that buprenorphine has been labeled to cause QTC prolongations. So I don't get EKGs on my patients that are starting buprenorphine, whereas when my patients start methadone, I have to check their QTCs. So yes, I would say methadone is predominantly a QTC prolonging agent.
Okay.
Do you hear me?
I think
Yes.
so.
Hi, I'm the one that posed those two questions, by the way. I'm Gustavo Goldstein. When we are talking about patients with abuse disorder, we are seeing really the tip of the iceberg. Most of the patients are complex patients that are in multiple medications. So although you might be right that with buprenorphine alone, the risk of QTC prolongation is minimal, frankly, most of my patients have several medications, many of which, each one of them, carry that worrisome QTC prolongation warning. So in practice, when do you do an EKG on a patient that you are using buprenorphine?
I mean, definitely with a lot of antipsychotics and psychiatric medications, that's something to worry about. I have not seen it in practice even when I have started buprenorphine on patients that have a slightly prolonged QTC. Have you seen it where you've started it and the QTC has prolonged further?
Well,
Or is it more like you're
we don't
anticipating?
usually use routine EKGs either. I just was wondering, as the use of buprenorphine gets more widespread, if we should start at least getting baseline EKGs before starting it. Not because of the buprenorphine in
Yeah.
itself, but because of all of the interactions with many other medications that we use for psychiatric patients.
That's an interesting question. I know in a hospital setting, because I do some addiction consult work in the inpatient setting, a lot of patients that have a QTC prolongation, we actually take them off of methadone and switch them to buprenorphine because we know it is going to be minimally, if at all, QTC prolonging. And at the end of the day, I think it's trying to figure out what the least effective or the least problematic agent is, because most of our patients that have an opioid use disorder need treatment. It's not like something you can pick and choose. It's more like if we don't treat them and discharge them without medications, the likelihood of overdose and death is very high. And so I think the approach that we take is which of these agents is minimally going to cause a problem, because most patients that necessarily aren't asking for Vivitrol or a complete antagonist are usually not going to do well if you're requiring them to take it. And so really then our hands are tied in terms of what we can do for treatment. And so if the question is methadone versus buprenorphine versus nothing, unless the QTC is so long that, you're worried about even a little bit of a change, I would still probably continue to use buprenorphine in that setting.
Okay, you gave way to my other question. Many of our patients are alcohol abusers and other, sometimes opioids, sometimes whatever else. Buprenorphine plus Vivitrol. Do you never? What?
Yeah, that's a great question because I know it came up a lot in terms of the overdose. What I do for my patients that use alcohol, but also have an opioid use disorder and are willing to start on buprenorphine is I start them on buprenorphine, but I do advise them that, in the setting that I'm giving you buprenorphine, if you continue to use alcohol, you are putting yourself at risk. Knowing that if I don't start the buprenorphine, they'll probably continue to use the illicit opioid. So their risk of overdose is actually much higher if they're going to continue to use the illicit opioid compared to me giving them a partial agonist like buprenorphine and letting them know that, they need to cut down. We can help them cut down. They're staying engaged in treatment and, possibly seeing us regularly despite the continued alcohol use. And, those are the patients you may need to see more regularly. Instead of seeing them every month, you might need to see them every week or every 2 weeks, just to make sure that they're stabilizing on the buprenorphine despite this other substance use disorder.
I agree with that. However, these patients, just because of the alcohol consumption, would be precisely the group in whom you would use Vivitrol. Obviously, if you have dual substances, one counter or produces the withdrawal on the other. Do you manage patients with both Vivitrol and buprenorphine, or you choose one or the other?
So just so I'm clear, because I have kind of a poor connection here. Your question is, would you try to convince them to be on Vivitrol over buprenorphine because of their concomitant or ongoing alcohol use disorder? Is that your question?
No, not in terms of convincing them, but in terms of biochemistry of the two compounds. One is a blocker that would produce withdrawal. The other is a partial agonist. Do you use both of them biochemically, both of them on a given patient.
Right. I do not use, so your question is, do I use Vivitrol and buprenorphine together?
Yes.
Okay. I do not use buprenorphine, and like you said, once an antagonist, it's not gonna work in the setting of buprenorphine, and it will probably precipitate withdrawal with that patient. So the buprenorphine will not be effective. I don't even think insurance would cover both. It might, I don't know, but typically I don't give patients buprenorphine and naltrexone at the same time, because one is pretty much just going to negate the other.
Thank you.
Now, if a patient gets off of their opioid, or say they haven't used opioids in years and now they're using drinking a lot, drinking heavily, then that might be a good indication to tell them, hey, let's start the Vivitrol, and this could also help with your opioid use disorder. But I don't typically do both at the same time.
Thank you very much.
We have two other questions. Have you seen pain in the upper half of spine as adverse effect of Suboxone, as a patient told me yesterday?
Okay, so they had pain in the spinal
says-
region?
Upper half of spine.
I have not seen that. Did they have any other withdrawal symptoms? Like, is this them precipitating withdrawal and now having more pain? Or is it just since they started on the buprenorphine, they're having pain in their cervical spine? Buprenorphine actually is a very strong pain medication, and what I tell my patients that have chronic pain is to split their no other withdrawal. Okay, yeah, I don't think that's a result of the buprenorphine. They may have some other cervical pathology, like arthritis. What I would recommend actually is to split their buprenorphine dose, because it's a very potent pain medication, and it can be effective if, they're splitting their dose instead of taking it once a day to help them with some pain relief. I think there was a question, I see some more. How long on average your patients tend to stay in the program? That's a great question. I think it's variable. I've had patients since I've started here. I started my addiction practice here at University of Maryland in 2020, and I've had patients that have been in this program for over 20 years, and I still see them. Whereas, especially with injectable buprenorphine, which we haven't talked about, the rates of dropout can be much higher because with the injectable form, patients don't necessarily have the withdrawal symptoms since it's so long acting until, months later. And so they can forget about continuing to take their injectable or coming in for those appointments and then start to have withdrawal and have dropped out of the program. In general, though, there is what I've seen is probably 30% dropout, maybe less, maybe more. It kind of varies. That being said, there is a lot of places locally. I'm in Baltimore, so there's a lot of different sites. So a lot of patients may come see me and then drop out, but then a month later I see they're at a different clinic, or now there's a mobile unit that comes right by their house. So patients have more access in Baltimore and are able to get treatment in other locations. But I couldn't tell you specifically how long on average patients stay. We do encourage them to stay similar to other chronic conditions, as long as it's an active issue for them, which could be lifelong. We try to keep them engaged as long as possible because, these patients are predisposed to a substance use disorder. And so if they were to relapse, they could overdose and die. So we never ask them to stop, or we never taper them unless it's like problematic and, we're not sure if they're taking it or there's other situations where they need to transfer. But we don't necessarily force patients to stop treatment for their opioid use disorder.
And it looks like there's one other question. Can you use Suboxone for both alcohol abuse disorder and OUD, since it has both components? New to this kind of prescription. Sorry for being naive.
No, that's an interesting thought, an interesting question. typically Suboxone hasn't been found effective to treat alcohol use disorder. It's mostly, even though naltrexone is effective, or at least somewhat effective, for alcohol use disorder, buprenorphine doesn't have the same effect, by binding partially to the, opioid receptors. I'm not really sure why the studies have shown that it's not, but patients don't really find that, and it's not really approved for that. If it indirectly, some patients find it helpful. Sometimes stopping one substance makes it easier for them to stop other substances because there's a lot of the social element of the use. Some patients I find when they get on treatment, it helps them treat a lot of their other substance use, especially like cocaine. Only because, they may only be using the cocaine as a stimulant to keep them up while they're on their opioid. And so if we get them on the right regimen, they may also stop using their cocaine. So it may indirectly help. But in and of itself, I haven't seen it necessarily have them treat the alcohol use disorder, if that makes sense. So it looks like there's a question about the GLP-1 agonists. That's a great question. Actually, our site right now is doing a study specifically for opioid use disorder. I don't think the results are out yet, but I think it is actively being studied if GLP-1 agonists are going to be effective for opioid use disorder. So we'll hopefully know in the next couple of years, because I think right now there's a lot of funding being put into them, especially in the addiction realm, since there have been some positive findings in alcohol use. I don't know if there's any results yet for opioid use, but I think the studies are definitely being done.
Yeah, for the rest of the audience, the GLP as Ozempic and Mounjaro, who everybody associated with either diabetes or weight loss. They are also being studied for other addiction or whatever you want to call it, disorders like obsessive compulsive and gambling and other things that are akin the dopamine system. So that's why I asked.
But more to come on that, hopefully in the next couple of years. All right, wonderful. I think we're about to hit our 10:30. Sorry for the late start. Does anyone else have any other questions before we adjourn?
If we do, Arnisha is free to email me and we can get those worked out.
All right, thanks everyone. Have a
Thank
nice
you.
day.
Okay,
Take
thank
care.
you so much.